everyone, welcome back to my channel. Today we're going to talk about primary biliary cholangitis, PBC. Primary biliary cholangitis, previously known as primary biliary cirrhosis, is an autoimmune liver disease resulting from your T lymphocytes attacking the intrahepatic bile ducts, also known as the bile ducts inside your liver. The bile ducts, by getting damaged slowly and progressively, undergoes necrosis and then becomes distorted, which leads to the obstruction of the bile flow, thus causing cholestasis. It consequently causes inflammation in the liver and also scarring, which eventually leads to cirrhosis. As with most autoimmune diseases, PBC is more common in females, and the female to male ratio is 9:1. It mostly affects the middle age, especially those between 30 and 60 years old. PBC has an association with other autoimmune diseases such as celiac disease, thyroiditis, SLE, Sjogren's syndrome, and rheumatoid arthritis. And about 60% of patients with PBC are known to have at least one other autoimmune diseases. HLA-DR8 is also another risk factor we should remember. So, what are the symptoms of PBC? 50 to 60% of all these cases are asymptomatic, and so in these cases, PBC is only found through liver function tests. In others, the commonly seen symptoms include fatigue and pruritus. Fatigue means tiredness and pruritus means itching. Fatigue is seen in around 80% of cases, and pruritus, itch, may present as the first symptom of PBC and is seen in up to 70% of patients and can interfere with quality of life. We can also see jaundice in more advanced cases. Right upper quadrant discomfort and swelling in the liver can be seen because there is inflammation in the liver. And other symptoms of PBC include hyperpigmentation, xanthelasmas, and dry mouth and eyes. If PBC has progressed to cirrhosis, you can see ascites, splenomegaly, and esophageal varices and hepatic encephalopathy. Patients with PBC are also known to have a higher risk of hepatocellular carcinoma and osteoporosis. Now let's see the mechanism on how we see the symptoms. So firstly, the T cells, they attack the intrahepatic bile duct, resulting in the cholestasis, which means the disruption in the bile flow. The liver becomes unable to remove the bile acids and also bilirubin from portal blood, leading to the accumulation of bilirubin and bile acid in the systemic circulation. Jaundice can be seen due to the increased serum bilirubin concentration, and increased bile acids in your systemic circulation causes itching. Bile also functions to excrete cholesterol, so with disrupted bile flow, cholesterol is retained, leading to hyperlipidemia. Thus, we can see the xanthelasmas, which means they are the yellow growths on the skin near your eyelids, which are caused by the deposits of cholesterol building up under the skin. The bile salts are needed to absorb fat and fat-soluble vitamins, which are vitamin A, D, K, and E. In cholestasis, the bile salts do not get delivered to the small intestine, resulting in the malabsorption of fat and fat-soluble vitamins. Especially with chronic vitamin D deficiency, there will be a higher risk of developing osteoporosis later on. The T cells attacking the intralobular bile duct, and the inflammation from it also damages the interlobular portal vein, thus causing portal hypertension. Portal hypertension can be seen starting from the early stages of PBC or even before it progresses to cirrhosis. If there is portal hypertension, we can see esophageal varices and splenomegaly, etc. Next, let's see the clinical findings of PBC. In the liver function test, we can see the prominent increase in the alkaline phosphatase and gamma-GTP, and normal or slight elevation of AST-ALT because it is a biliary tract disease. And also, as I mentioned before, we can also see an increase in serum concentration of bilirubin and cholesterol. Diagnosis is by testing the antibodies found in the PBC. The most specific antibody is the anti-mitochondrial antibodies, AMA. They are most specific because they are found in 90% of cases with PBC. These AMA antibodies attack the pyruvate dehydrogenase E2 on biliary epithelial cells. Anti-nuclear antibodies can also be tested, and they are present in 50% of the cases. Imaging, such as abdominal ultrasound and MRCP, which means magnetic resonance cholangiopancreatography, are done to exclude PSC and also masses causing obstructions in the bile duct. MRCP is typically normal in PBC because PBC is the inflammation of the very small bile ducts inside the liver, not the extrahepatic bile duct. Definitive diagnosis is by liver biopsy. The histological findings include non-suppurative chronic biliary duct destruction. It is called non-suppurative because in PBC, the cells responsible are not neutrophils. If it's neutrophil, it will be suppurative, but in PBC, do you remember what cells are responsible? Yes, they are T lymphocytes. So it is non-suppurative chronic biliary duct destruction. Okay, next let's see the treatments. Firstly, urodeoxycholic acid, UDCA, is commonly used first. It is used to decrease liver inflammation and damage. However, around 40% of patients are resistant to UDCA. If UDCA treatment failed, obeticholic acid can be used. As for symptomatic therapy, to treat pruritus, we can use cholestyramine, antihistamine, and UV light therapy. Statin can also be used to improve both hypercholesterolemia and cholestasis. In advanced stage PBC patients, liver transplant becomes the only option. However, the recurrence of PBC can be seen in 20% of cases after the liver transplant. Lastly, let's go through the overview of PBC once again. So what is PBC? It's an autoimmune disease where the T cells attack the intrahepatic bile ducts very slowly and progressively, thus they get damaged and get distorted, thus causing cholestasis. And it will eventually affect your liver and causes scarring, fibrosis, and eventually cirrhosis. Half of them are asymptomatic, but the most common symptoms include fatigue and pruritus. You can also see jaundice. Other symptoms include right upper quadrant discomfort and swelling, and hyperpigmentation, xanthelasma, dry mouth and eyes, and even symptoms of cirrhosis if it progressed. And the risk factors include being female and having a family history of autoimmune diseases and having HLA-DR8. And patients with PBC have an increased risk of developing hepatocellular carcinoma and osteoporosis. The clinical findings include elevation in ALP and gamma GTP, and also bilirubin and cholesterol serum concentrations. The antibodies we should remember are anti-mitochondrial antibodies, as these are the most specific ones, and also anti-nuclear antibodies. In the imaging, MRCP is usually normal in PBC. And for definitive diagnosis, we do liver biopsy and we can see non-suppurative chronic biliary tract destruction. And the treatments include UDCA, and if it failed, we use obeticholic acid. And for pruritus, we should use cholestyramine and antihistamine. And in order to treat the hypercholesterolemia, we use statin. And then you can use liver transplant as a last resort. And there will be 20% recurrence. Okay, that's it for PBC. So I will leave a link in the description box where you can download these notes. And I hope you liked this video. If it was helpful, please don't forget to give a like and please subscribe to my channel. And also please feel free to leave a comment. Thank you very much for listening.